Hello, good morning. Very warm welcome to yet another podcast from PACESDIARIES.UK. This is Dr. Moses Wesley. Today, I will be the host and we have a special guest. And before that, I would like to announce that we are going to have a series of topics to be discussed. These topics are going to be based on the acute medicine, like how we are going to deal with some medicine related emergencies, with some case scenarios and some differentials and approach based on latest guidelines that is available. And today's topic is going to be very interesting. A patient presenting to you with coma, a comatose patient, and what we have to do, how to deal with that. For that, we have a special guest with us, Dr. Muhammad Ibrahim, and I have no words to tell about him. I can talk about him a lot, and he is one of the very finest critical care consultant. He has finished his MD, DNB, and Mrcp UK, and he's from Trichy, and we have practiced with each other for our Mrcp UK PACES examination, and he's a good friend and a brother, and we warmly welcome you, sir, Dr. Muhammad Ibrahim.
Yes, thank you, Dr. Moses, for a warm welcome. Thanks.
All right, and today's topic is coma. All right, so the very
Yes.
first thing is like, we would like to know, sir, like, what exactly is a coma?
Coma, simply you can say it is an unconscious state. Patient is in unconscious state, not responding to a painful stimuli. Yeah, it's like a deep sleep-like state with eyes closed from which patient couldn't be aroused by painful stimuli.
All right, so with the coma, there are a lot of other terms are like come interchangeably, right? This people call somebody is a lethargic, somebody is a stupor, and even we have terms like semi-coma. Can you just shed some light on those topics, sir?
Yes, Dr. Moses. Yeah, there are certain conditions which can mimic coma. Etiology-wise, more of same to coma, but the presentation differs slightly. As we can say, a patient is stuporous, means they are responding minimally to pain. There can be slight flickering movements to pain, maybe there. In coma, there is no movement at all. And other condition is akinetic mutism, in which patient eyes are open, patient appears to be awake, but they are motionless, speechless. Another condition is locked in state, in which patient remains motionless, except for eye blinking and vertical gaze are present.
Okay.
Yes.
All right. So the locked-in syndrome, typically the one we get, even during the central pontine myelinosis and other stuff,
Yes.
where the patient will be typically quadriparetic, only the vertical eye movement will be preserved, and the consciousness will also be preserved over there, I think.
They appears to be awake because of eye opening, but there is no other motions at all, except vertical gaze and eye blinking, no other movements.
Okay. Yes, that's absolutely. So these are the coma mimics, right? Am I right? These are the
Yes.
coma mimics.
Yes.
So practically, when we get a patient who is comatose, all right. So this scenario, and all of your listeners, the same thing can be asked for you in any exams. Just remember, these are very common questions in NHS interviews as well, right? So practically, when a patient is coming to you who is comatose, so how do you approach? Because these cases you do get day to day in your critical care practice. So how are you going to approach such patients?
Yes. Before going to approach of the coma patient, I want to say about the etiology, causes of coma. So it will be easy to approach the patient then. And going to the etiology of coma, we can divide into two broad classification: non-structural and structural. I mean, structural means there should be pathology radiologically in CT or MRI brain. You are able to you are able to find an anomaly in there. It can be hemorrhage, infarct, or any trauma, or it can be any tumor in the MRI or CT brain. That is structural causes. If you're taking an CT or MRI in coma patient, it appears to be normal, then it is non-structural causes. There are a lot of non-structural causes are there. Just I want to brief it for you. Non-structural causes, it can be metabolic, or it can be infective, or it can be seizure related. In metabolic, it can be hyper or hypoglycemia, electrolyte imbalances, uremic NCAF, hepatic NCAF. It can be hypertensive encephalopathy. These all the reasons can be metabolic. Infective, it can be meningitis or encephalitis. Seizure, especially non-convulsive status epilepticus. Even though patient is having seizure, we are not able to identify it from the appearance of the patient. There couldn't be any jerky movement at all, but seizure will be going on. Only through EEG we will be able to identify it. And I said about metabolic, infective, and seizure related. Then other causes is important is drug overdoses, especially when younger patients come to you, middle-aged persons. It can be drug overdoses, can be and poisons too, like opioids, sedatives, alcohol related. It can be. If and other rare causes, it can be vasculitis, SLE, autoimmune related. We can say autoimmune related. And other causes in non-structural, I want to say hypothermia, heat stroke, hypoxic encephalopathy. These are other causes. Yes. Now we'll go to the. Can we go to the approach, Dr. Moses?
Yes, now we can go to the approach. So if a comatose patient comes, so what exactly we have to do? Like, this will be tremendously helpful for especially junior doctors and, the medical registrars who are just now getting inducted into the NHS system. Can you just brief us, like, how we are going to approach such patients?
Yes. When a patient present to you in an emergency in an unconscious state, first check whether they are unconscious or not by uh, trying to arousing them by verbal commands. Hi, hello, man. You can try to arouse through your commands, oral commands. If they are not awaking, give painful stimuli. Painful stimuli can be given at the sternum by using a knuckle or by pinching, or it can be given pain at the supraorbital ridge. If they are not responding to the pain at all, check for the carotid pulse. If carotid pulse is not there, means patient is went into cardiopulmonary arrest. You have to give CPR as per as ESCLS protocol. That is the scenario different. And if carotid pulse is present, the patients come under the criteria of coma. Now, next, immediately assess for airway, breathing, circulation. Try to stabilize them side by side. Assess the patient. Four important things pertaining to coma are assess for the pupils, dorsal movement, breathing pattern, or any specific posturing to your spine. Now I will tell you what are the findings you have to note in these 4 points. Pupils will give a lot of clues to you. I'll give different things for findings and their interpretations. If pupil appears anisochoric, I mean one side dilated, other side is constricted, that means there is an brainstem compression is there. Can be lead to any unilateral pathologies like hemorrhage or any SOL or any infarct causing edema in one side of the cerebrum. If both the people are constricted less than 1 m pinpointed, it can be point and hemorrhage or opioid overdose. If both people appears to be 1 to 2 mm reacting, it can be metabolic cause. If both people appears to be dilated, both dilated, it can be alcohol related or both any midbrain lesion can it be. These are the inferences from your pupils itself. And assess for the dorsal movement. If dorsal movement is absent, it means there is a pathology in the brainstem or in the pathology in the cerebral cortex causing compression in the brainstem. If you have dorsal movement present, you can say strongly something metabolic problem is going on, mean non-structural problem is going on. This is a clue. These are the clues from your dorsal movement. Next thing, you check for the any posturing. When you are getting pain, look for the any posturing movement of the limbs. It can be decelerate, decorticate, or you can note sometime movement can be absent in one side of the upper limb and lower limb. Patient can have a stroke in one side. That also you can note from your posturing. Decerebrate posturing occurs in case of the problem above the midbrain. It can be cortex or basal ganglia. Decerebrate occurs below the midbrain, especially in the brainstem issues. You can get in decerebrate posturing. We'll post the images of the posturing in our Paces Diary website too.
Definitely, definitely.
Yeah. And I told about you the pupils and posturing. Then the breathing pattern. So most of the patients don't present with that. Can be chain strokes breathing, Biot's breathing, ataxic breathing can it be. Chinese stroke breathing occurs in case of diffuse cerebral pathology, and ataxic breathing occurs in the the brainstem lesions. And I told you about the pupils, Dalsey movement, breathing pattern, and posture. These are the peculiar things to be noted in case coma patient. Then going to the vitals. Side by side to assess the vitals, now the sugar is also becoming the vitals today. Don't forget checking the sugar at the presentation itself. It can be a simple hypoglycemia causing a coma. Can be reversible as much as yearly or treating it. Vitals, I will tell you how vitals is helping you to get the cause of the patient. Heart rate, it can be a tachy or bradycardia. It can be tachyarrhythmia leading to syncope. It can be bradyarrhythmia causing a syncope. And BP, blood pressure. It can be hypotension causing a cerebral hypoperfusion. Hypertension, if you're getting hypertension, it can mean hypertension encephalopathy. Then coming to respiratory rate, if you're getting in a patient bradypnea, it can be related to brainstem lesion, or it can be an drug overdoses like opioid and benzodiazepines. If I have a patient in tachypnea state, increased respiratory rate, it means patient can be in acidosis, having a metabolic acidosis, compensatory breathing is there. So your vitals will help you to arrive at a cause. I told you about your pulse rate, blood pressure, respiratory rate, and then coming to temperature. Temperature is very important. Patient can have hypothermia or hyperthermia. Hypothermia is important cause for coma. Temperature less than 30 degree. Important cause. And even it can mimic as a brain death too. Hyperthermia, patient can present with you heat stroke. That's also important thing. So I told you about the vitals. And then the saturation, then the pulse oximetry. Hypoxia can also cause encephalopathy. So I conclude here about importance of vitals here. Then coming to going to systemic examination from head to toe in the coma patient. Can I proceed?
Yes, yes, please. We would like to know what are the things the candidates are and the registrars, at the level of an internal medicine consultant. We need to know what examination we have to do, all right, immediately in a
Yeah.
patient who is in coma.
Yes. I repeat, after completing the ABC assessment, then 4 peculiar things: pupils, Dalsey movement, respiratory pattern, and posturing. Then going to vitals. Then you come to systemic examination of head to toe in a coma patient. Starting from head, look for any injury, any traumatic injury there, any ear bleed, any contusion, any ecchymosis around the eyes. You search for any trauma related findings. And then in the eyes, look for ITROs. It can be related to hepatic encephalopathy. And look for any eye movements, conjugate eye deviation. It can be you can have movement related to oculogyric crisis, which can occur in certain drugs. These are the things you should note in the eyes. I already told you about the pupils and Dalsey movement. That also comes in eyes too. Then going down, look for any tongue bite in the mouth that can be related to seizure. And look for any peculiar smell related to any poisons. In India, we tend to have OPC poisoning, organophosphorus compound have peculiar smell, pungent smell can be there. And going down in the neck, look for hang mark. It can be the patient after hanging attempt. They can be in hypoxic encephalopathy. It can be attempted hanging patient with hypoxic ischemic encephalopathy. So don't forget to check for hang mark in their neck and look for the neck stiffness. It can be related to meningitis or meningoencephalitis. Coming down in the hands, in the extremities, look for any IV drug abuse, IV marks. Can be patient can be an IV drug abuser, so they can have a drug overdose dose related complication. Look for any cyanosis in the extremities. Can be related to hypoxia or can be related to shock. Look for any rashes, petechiae purpura, that can occur in case of meningitis, especially meningococcal meningitis, severe sepsis, any bleeding disorder, thrombocytic purpura. These are the certain conditions which can present with petechiae and purpura. And look for any other injuries too in the extremities. And I told you already about the checking for the movements of the extremities, doing the giving the pain itself. You can easily identify the stroke patients from them. And going down in the chest, auscultate for any murmurs, Murmurs can be related to infective endocarditis causing a septic emboli in the brain. And look for any crackles in the respiratory system. Patient could have aspirated after in comatose state. And abdomen, look for any distension. It can be related to a chronic liver disease having hepatic encephalopathy. Or look for any organomegaly there. And going down in the legs, look for the peripheral pulses. Look for cold peripheries. They can be related to shock or hypothermia. You can look, these are the things from head to toe examination. Is it clear, Dr. Moses?
Absolutely, a fantastic list and easy to remember. The same thing you remember, we always go for a head-to-toe
Yeah,
approach.
yeah.
Even during the clinical consultation, history
Yeah,
taking, we do a head-to-toe approach. So, and anyone will not miss anything, right? Like seeing the patient, they know what to do. They can cover up everything and in a quick succession. All right, that's beautiful. So, what are the investigations, doctor, we need to do? Like what investigations exactly we need to take and we need to send immediately in a comatose patient?
Yeah. Coming to investigation, as I already told you, the causes are divided into two. It's the structural, non-structural. It is mainly divided by radiology only. So the CT or MRI brain is very important in a comatose patient. It should be done after securing ABC. The vitals should be stabilized, then patient should be shifted for investigation, MRI or CT. If CT or MRI tends to be normal, then you think of metabolic causes. Do the basic investigations like CBC that can show an increased counts that suggest of infection, low platelets, any suggestion of maybe bleeding, and renal function test suggestion of uremic encephalopathy. Yeah, liver function test to rule out hepatic encephalopathy. You can check urine serum ammonia too for that. And then check for all the electrolytes, sodium, potassium, magnesium, calcium, phosphate, uric acid. Every electrolyte should be checked. And the TSH to rule out myxedema coma. And then uh, uh, do an ECG to rule out any arrhythmias. This X-ray to rule out any aspiration. These are the basic investigation should be done in a comatose patient. These are the first tier investigation. If everything tend to be normal, then go to the second tier investigation. If you are suspecting a meningitis, CNS infection, you can do a lumbar puncture and do CSF analysis. You can do an electroencephalography, EEG, if you are suspecting any seizure. You can do an autoimmune panel like ANA if you are suspecting vasculitis. If you can do drug screening and toxicology panel if you are suspecting any poisoning. These are second tier investigations. These are the investigation I want to tell in coma patients.
That's fantastic. We got a good list of investigations. And please don't forget, like Dr. Ibrahim said, like Tier 1 and Tier 2 investigations and what exactly you have to look for. These are the things we need to do in a very quick succession in an acute medicine or in a critical care settings. Okay. All right. So can you shed some light on some management? Some basics of that.
It is a wide area of topic. Time concerning, I can say simply some note on management. First, as I already told, the causes are structural, non-structural. Structural causes, mainly the neurosurgical intervention comes here. Even as a internal medicine person, you can give an anti-edema measures to reduce an intracranial tension in structural causes. You can use mannitol after checking RFT. You can use 3% NS, normal saline 3% if RFT is altered, head and elevation. And when you have intubated the patient, increase the respiratory rate to wash out the CO2, reduce ICT. These are the basic things you can have to do to reduce the intracranial tension in a structural cause causing a coma patient. If you're getting a non-structural causes, if you're getting a non-structural cause for a coma patient after ruling out through CT or MRI brain, depends on the cause. It simply, you correct the electrolytes, you correct the glucose, take a dialysis for uremic encephalopathy, give lactulose enema for hepatic encephalopathy, give thyroxine for hypomyxedema coma, stabilize the vitals, BP, heart rate, saturation. You have to stabilize everything. Give antibiotic, you are suspecting an infection. These are the basic measures you should take. And don't forget to give an DVT prophylaxis in a coma patient after ruling bleed in the CT or CT. And don't forget the nutrition of the patient. And you should prevent the bed sores too in a coma patients. They should be encouraged in the staff, nursing staff should be encouraged to prevent bed sores by changing the posture of the patient every second hourly. And DVT prophylaxis is also very important. So I think I want to focus on in coma patients. Thank you.
Thank you. Thank you so much, Dr. Ibrahim. Like, we learned a lot of things today. To summarize, we know what is a coma and what are the mimics of coma, and how do we practically approach to coma, like, from quick examination and investigations and management. These are the things we need. This is a framework that has been given, and about coma we can learn a lot of things in the upcoming podcast sessions, and we are going to learn a lot of acute medicine scenarios about how to manage and what exactly has to be done. All right, I hope this helps, and we will meet again with another scenario soon. And thank you so much for listening, and please do visit our sites www.pacesdiaries.uk and our YouTube channel Paces Diaries, and do like and subscribe and share this if you really like this. And thank you so much, Dr. Ibrahim, for coming up all the way here, and we would like to meet you again soon with another podcast. Thank you.
Thank you. Thank you.